Hey guys, so this is biomechanics and kinesiology of the sacroiliac joint. So what are the functions of the sacroiliac joint? Of course, it acts as a link in between the axial skeleton, the spine, and the lower extremity. It's responsible for transmitting all the forces from the upper extremity to the lower while standing and transmitting forces from the upper extremities and the axial skeleton to the ischial tuberosities while sitting. The bones that comprise the sacroiliac joint provide an attachment site for, of course, for multiple key and large muscles of the trunk and lower extremities. And one of the main functions of the sacroiliac joint is to absorb the ground reaction forces in standing and sitting activity. So, remember, as we spoke about in one of the first classes, for every action there is an equal and opposite reaction. So once again, we keep hearing about the ground reaction forces. Anytime our foot touches the ground, we have a force going from our foot into the ground. And of course, there's an equal and opposite force coming from the ground to our foot. So very important to remember. We're going to talk about it in posture and gait lectures as well. So once again, SI joint responsible for transfer of forces. We have transfer of forces from in standing, from lumbar spine to sacroiliac joint to ilium to femoroacetabular joint and down to the ground. And in sitting, the forces are being distributed from the lumbar spine through the sacroiliac joint and down to the ischial tuberosities right here to the chair. So anatomy review. We're going to be looking at the whole pelvic complex. So it's not just the sacroiliac joint. As a therapist, you have to appreciate the complexity of the whole pelvic complex. So of course, it's composed of the two innominate, the right and the left one. We have the sacrum sitting right here in between, and L4, L5 just above the sacrum. In terms of joint, we have the sacroiliac joint, number one, and number two, the right and the left. We have the pubic symphysis right here, symphysis pubis joint, and that is a cartilaginous joint in between the two innominates. We have articulation between L5 and S1, which we mentioned in the lumbar lecture, but we'll go over that one more time. And of course, we have the acetabular-femoral joint, and we covered that in the hip lecture. Of course, as you think about the function of the sacroiliac joint, you're going to think about the need to transfer forces, as we mentioned a second ago. So we will require a dense and complex ligamentous network in order to stabilize the joint that constantly is responsible for force transfer from the superior body or from the ground reaction forces that are acting upon it. So the muscles in the sacral and lumbar plexuses are not something that we're going to be looking at in this lecture. Okay, so the sacrum itself. So the sacrum is the triangular bone right here, right? It's made out of the 5 fused bones, S1 through S5. It has a base, and you have to remember that the base is superior, and the apex is inferior right here around the inferior portion of S5. So the anterior surface is right here, and the posterior surface is showing on the right. The anterior surface is smooth and concave, of course, allowing the organs to sit on the inner side of the pelvic ring, and the posterior side of the sacrum is not smooth, of course, and that is, of course, for attachment of the various ligamentous networks and muscles. The lateral surfaces are the auricular surfaces, so they're located right here, and they're rough and articulating with the two innominates. So the superior surface accesses stout superior articular processes. So these are the superior articular processes articulating with L5. So with inferior articular processes of L5. We also have a sacral base, which I mentioned earlier. So it spans from the most lateral side to the other most lateral side of the sacrum. The articular surfaces, the articular facets face close to posterior and slightly medial, and we spoke about the frontal plane articulation of the facet joints, and we'll mention it in a few slides again. So it's important to note the location of sacral promontory. So it sits right here. As we're going to dive into the biomechanics of the sacral joint, you're going to notice that we refer to sacral promontory going anterior or posterior. So it's important for you guys to know where it actually sits. Lumbar facet joints. So just a second ago, we mentioned the arts of the orientation of the sacral facet joints. So this is orientation of the lumbar facet joints. So we know that the inferior articular process of the superior vertebrae, right? So inferior articular process of the superior vertebrae articulates with the superior articular process of the inferior vertebrae, right? So that's what I'm showing here. L4 articulating with L5. So the general consensus is that L1 through L4 is typically in line with the sagittal plane. So we can see the facet orientation right here, and it's more in the sagittal plane. But as we get down lower, we get closer and closer to the frontal plane. And here you can really see it clearly, the orientation of the joint in the frontal plane, right? So that's going to be important for the stability of the sacroiliac joint. Um, so the superior facet of L5 faces posteriorly, right? So we can see the superior facet of L5 facing posteriorly, and the inferior facet of L5 all faces close to anterior and slightly lateral. So this is the inferior facet. We can see how it faces anterior and slightly lateral in order to meet the medially oriented sacral facets. So lumbosacral junction is a transition zone from one region of the spine to the next. And transition zones are typically the frequent areas of pain and dysfunction in the body. So lumbosacral junction is composed of the intervertebral disc, just like any other lumbar joint, right? So we have the vertebrae disc and the vertebrae articulating. Well, in this case, it's going to be the base of the sacrum. And posteriorly, we have two joints articulating together. Once again, it's two facet joints. They're plain synovial joints, and gliding will be allowed at these joints. So the inferior facet of L5, which faces anterior to slightly lateral, which I mentioned a slide ago, will be articulating with the superior facet of S1, right here, right? This is the superior facet of S1, which faces posteriorly to slightly medial. Okay, so now we're gonna take a look at the iliolumbar ligament. So you guys probably remember from anatomy. So iliolumbar ligament starts from the transverse processes of L4 and L5, also adjacent fibers of quadratus lumborum, and inserts inferiorly right here to the ilium, just anterior to the sacroiliac joint. So they attach to the upper lateral aspect of the sacrum. So the function of iliolumbar ligament is to actually stabilize the lumbar vertebrae and prevent the anterior and rotational translations of the L5 and S1. So basically stabilize L5 in multiple directions on on S1. So we're going to take a look at poor stabilization in just 2 slides of the iliolumbar ligament. ALL. So once again, we mentioned the ALL a number of times, starting from the cervical spine to the lumbar spine, and it extends down all the way to the lumbosacral junction right here. So it starts from the basal part of the occipital bone and inserts, goes through interior surfaces of all the lumbar vertebrae right here. It starts off thinner and then widens as it goes down closer to the lumbar spine. And once again, it has to reinforce that lordosis created by the lumbar spine. The fibers of the anterior longitudinal ligament also blend into the anterior portions of the disc, so it creates reinforcements of the disc upon on the vertebrae. So it's twice the tensile strength of the PLL that's pretty thin in the lumbar spine, as we mentioned. So once again, the function is to restrain extension in the lumbar spine and to resist excessive lumbar spine lordosis. So it also acts as a passive barrier to resist excessive anterior shear force that acting upon all on all the vertebrae and the sacrum. So we're gonna mention anterior shear, but I just want to um, just show you what I actually mean. So the anterior shear force is going to be simply an anterior translational force of the vertebrae upon the inferior portion of the other vertebrae, or the sacrum in this case. So anterior shear of L5 would be anterior translation of L5 on S1. And we're going to dive into it right now. So lumbosacral angle is something that I mentioned in class, and I mentioned spondylolisthesis in class as well, but we're going to go over it again just to make sure that you guys have the slides. So lumbosacral angle is the articulation in between L5 and S1, and the angle that's created in between the two vertebrae. You can see there's a certain calculation that you have to do in order to actually calculate the angle. But the base of the sacrum is naturally inclined anteriorly, right? You can see how the base is slightly more anterior than the vertebrae right here. And this anterior inferior orientation of the sacrum forms the 40-degree angle in standing of the L5 and S1 junction. So the body weight that comes from above essentially creates shear force. So there's constant shear force going. I'm just going to put the line in again for you. So there is a constant shear force of L5 trying to translate forward on S1. So a typical 40-degree angle will produce an interior shear force of about 64% of the body weight. So if this angle right here increases to about 50 degrees, meaning that the sacrum will rotate more and the angle will increase, the forces that are translated, that are acting upon L5 on S1, will be increased to about 82%. So the shear forces of translation, the body's weight will naturally push S1 anteriorly right here on sacrum. And that is, of course, is not good for our body. So the reason, you see, 64% is already a lot, right? So this is the reason why we have that frontal plane articulation of the, right here, the frontal plane articulation of the joints. This is the mechanical blockage of the um, of the L5 on S1, right? That doesn't prevent, if you can see, if L5 wanted to translate forward on S1, it wouldn't be able to because there is a mechanical stop of S1 superior facets. Also, as you notice, there is this anterior longitudinal ligament that's going to prevent L5 sliding forward. So that's an important fact to note. So lumbosacral angle. So the orientation of L5 and S1 facet joints near the frontal plane makes them ideally situated to resist the anterior shear, right? So additional passive stabilizers would be the ALL, just like I mentioned a second ago, and the iliolumbar ligament. So unchecked anterior shear can lead to what condition? And that's something I mentioned in class. It's going to lead to a fracture of pars articularis, so the area in between the superior and inferior articular processes of the vertebrae. And this will essentially create a condition known as anterior spondylolisthesis, or typically just referred to as spondylolisthesis of L5 and S1. So once again, I'll show you the angle right here. So if you take a look at the MRI, you see how the vertebral bodies are all kind of aligned with each other. So here's the vertebral body, another vertebral body, L4, L5 right here. But if you take a look at the sacral base right here and L5, you will notice this little space right here in between L5 and S1, right? This very little space right here that's not covered. So this space is essentially the slippage of L5 and S1. So because L5 was translating forward, because probably of increased lumbosacral angle, poor stabilization from anterior longitudinal ligament, and possibly anatomically oriented facets more in the sagittal plane rather than the frontal plane created this condition where L5 will be slipping on S1 and creating this. It's about 25% slip of the vertebrae on the sacrum. So this is just a condition to note. You guys will come across spondylolisthesis in many other classes, but it's important to know. So let's take a look at sacroiliac joint ligaments. So, sacroiliac joint is a rigid articulation, right? So you have irregular rough articular surfaces of the sacrum articulating with irregular rough articular surfaces of the ilium. But it's important to remember that the sacroiliac joint actually sits in a vertical plane, right? So there is some sort of translation happening through the sacroiliac joint. And because of that, we do need that extensive ligamentous support. So, the sacral base is covered with hyaline cartilage. The ilium is, sorry, not the sacral base. The sacral articulation with the ilium is covered with articular cartilage, and the ilium is covered with fibrocartilage. Um, the joint capsule is present in between the two joints, the sacroiliac joint, and there is synovial fluid inside the joint capsule as well. Ligamentous support, of course, there is extensive ligamentous support. So, we have three primary stabilizing ligaments of the sacroiliac joint. We also have three accessory stabilizing ligaments of the sacroiliac joint. So the three primary stabilizing ligaments would be the anterior sacroiliac joint, the posterior sacroiliac ligament, sorry, and the interosseous sacroiliac ligament. The three accessory stabilizing ligaments would be iliolumbar ligament, sacrotuberous ligament, and sacrospinous ligament. So let's take a look at each one in detail. So, anterior sacroiliac ligament, of course, just as it sounds, it's right here highlighted in pink. So we have multiple fibers spanning from the sacrum onto the ilium, and it's on the anterior surface of the sacroiliac junction. So basically, what the anterior sacroiliac ligament is a thickening of the anterior joint capsule, and it resists separation of the sacroiliac joint. So once again, here the separation forces. So if the ilium were to go in one direction and the sacrum were to go in the opposite direction. Okay, so that's what this ligament exactly resists. Okay, so the posterior sacroiliac ligament, it's much thicker than the anterior sacroiliac ligament. They're short and long fibers of the posterior sacroiliac ligament. The short fibers are typically deeper. So this is the posterior sacroiliac ligament, and we have more extensive network right here. So the short fibers are deep, and they start off from PSAS and go to S1 and S2. And the long fibers start from PSAS and go to S3 or S4 lower down to the sacral apex. So the function of the sacroiliac of the posterior sacroiliac ligaments are very important. By the way, they're also called the long dorsal ligament. So posterior sacroiliac ligament is also known as a long dorsal ligament or posterior sacroiliac ligament, as I presented here. So the function. So both ligaments, the deep and the long fibers, become taut during counter-nutation of the sacrum. We're going to go over the motions of the sacrum, but for now you need to know that it becomes taut with counter-nutation. Both fibers will resist excessive counter-nutation of the sacrum. Once again, very, very important to know. And we'll go over the motions in a few slides once we do biomechanics. So counter-nutation is resisted by posterior sacroiliac ligament. There posterior sacroiliac ligament is placed on slack during nutation motion of the sacrum. Okay, so once again, we'll take a look at the motions in a few slides. Interosseous ligaments. So interosseous ligaments are little ligaments that span from here to here. You can see multiple fibers, right? So it's a collection of short and very strong ligaments that fill in most of the relatively wide gap that exists in between the innominates and the sacrum. It acts as an interosseous membrane or syndesmosis between the innominates and the sacrum, and it strongly binds the innominates to the sacrum. So once again, it resists that separation of the ilium on the sacrum. Now we're going to go into the 3 accessory ligaments. So we have the iliolumbar ligament that we mentioned earlier. We have the sacrotuberous ligament and the sacrospinous ligament. So let's take a look at these. So the sacrotuberous ligament is right here, sacrotuberous ligament. So it spans from the sacrum onto the ischial tuberosity. So this is it right here, sacrotuberous ligament. It's a large ligament, and essentially it blends with some fibers of the superior ligament right here. Some of it go all the way up to PSS. They span from the lateral portions of the sacrum and inserts onto the ischial tuberosity. The fibers blend with bicep femoris and posterior sacroiliac ligament. And some of the fibers also blend with gluteus maximus in the posterior section right here. So the sacrospinous ligament, it's right here. So it starts from it's deep to the sacrotuberous ligament, as you can tell. This is the sacrotuberous, and this is the sacrospinous ligament. So it's lateral caudal end of the sacrum, and it goes to the ischial spine. So ischial spine right here. Both sacrotuberous and sacrospinous ligaments, so number 1 and number 2, they both resist nutation, okay? So nutation of the sacrum is resisted by sacrotuberous and sacrospinous ligaments. Important to know. So, nutation of the sacrum, okay, will be sacrum. We're going to go over it in a second, but I'll just cover it right here just so you guys know. Nutation of the sacrum is the sacral promontory right here going interior. And thus, if you can imagine the sacral promontory going interior, the apex of the sacrum right here will be going posterior. So we'll be going in the opposite direction. So it will be going upwards like that. So the sacral promontory will be going interior, and the apex will be going posterior superior. Okay, so this motion is called counter-nutation. And as you can tell, if the apex is going to be going upwards, right, and back, these two ligaments, the sacrospinous ligament and sacrotuberous ligament, will prevent the apex of going in that direction. So these two ligaments, once again, they're responsible for preventing nutation motion of the sacrum. So finally, let's take a look at the kinematics motions of the sacrum. So sacrum is one of the most difficult joints to assess in their entire body. The sacroiliac joint typically reported to be a source of pain in about 15 to 30% of patients with chronic lower back pain. So there's a bunch of different tests that you guys will learn through the program that you can use as a cluster of tests to assess the sacroiliac joint. There is also ligamentous stability test that you guys will learn. But these are some typical tests that are presented to you in physical therapy school that I use to assess the stability of the sacroiliac joint. Okay, so motions of the sacrum within the sacroiliac joint. It typically occurs on the medial to lateral axis of rotation, the location of which has yet to be conclusively determined. the amount of motion under typical circumstances is very, very small. So that's why, some physical therapy schools, they argue that it's impossible to assess the motion of the sacroiliac joint with manual palpation, while other schools of thought, they think that you can actually palpate the sacroiliac joint. It really depends whose research you look into. Um, but the typical ranges of motion for sacral rotation would be 1 to 8 degrees of total rotation. So that's pretty small, right? And it ranges from zero point 0.5 to about 8 millimeters of translation in motion. So the physiologic and clinical significance of sacroiliac joint motion has been in the main ignored by all except for OBGYNs, right? And clinicians who actually regularly deal with SI joint syndromes. So sacroiliac joint is very interesting joint for you to look into. Of course, if you're going into orthopedics, or if you're going into pelvic floor as a manual therapist, sacroiliac joint has a lot of biomechanics and anatomy to explore. So that would be an interesting joint to look into later on in life. So sacral motion, finally we get into it. So like I mentioned, there are two typical motions of the sacrum. There is nutation motion and counter nutation. So nutation means to nod, right? So the sacrum, you can imagine, is nodding forward, right? Nutation to nod. So the base of the sacrum will tilt anteriorly and slightly inferior, while the apex of the sacrum will move posterior and slightly superior, okay? The sacral promontory, like I mentioned earlier, will move anteriorly, okay? So just spatial orientation for you. Counter nutation will be the opposite. Counter nutation will be the base tilting posteriorly and the apex moving anteriorly and slightly inferior, right? The sacral promontory will be moving posterior. So once again, nutation means to nod. The sacral base will be going anteriorly. Counter nutation is the sacral base moving posteriorly on the ilium. So sacral motion is also associated with the innominate motion. So we're just gonna layer on top of the knowledge that we received just now. So nutation means to nod. The base will be going anteriorly and slightly inferior. The apex will be moving posteriorly, and the sacral promontory will be moving anteriorly. Nutation of the sacrum occurs with a posterior tilt of the innominates on the stationary femur. So this is obviously nutation, right? The base is going anterior. And you can picture how the sacrum is moving anteriorly, right here, the base of the sacrum, but the innominate will actually be moving posteriorly. So whether it's a relative motion, meaning that the sacrum is moving and the ilium is stationary, or it's an actual motion of the sacrum moving forward and the ilium moving back. Either or, in either or case, you will have the sacrum moving in one direction and the ilium moving in the opposite direction. So counter nutation will be the opposite. So counter nutation is typically associated with anterior tilt of the innominate on the stationary femur. Okay, so if the sacrum will be going into counter nutation, the base of the sacrum is moving posteriorly, tilting posterior. The ilium will be, and the innominates, the whole innominate, will be creating an anterior pelvic tilt. Okay, so counter nutation is associated with an anterior pelvic tilt. So let's layer some knowledge on top of that. So lumbar-pelvic rhythm we mentioned in the lumbar spine. So I mentioned during the lumbar-pelvic rhythm, you guys remember how the spine goes forward into flexion. Then at some point we have the innominates following the spine and going into anterior rotation of the innominates. But now we know that the sacrum is also another player in the game. And what happens with the sacrum is that it goes into counter nutation, right? So if the innominate goes into anterior rotation, the sacrum will be going into counter nutation. So the sacral base will be moving posteriorly, while the sacral apex will be moving anteriorly. Okay, so the ligaments that engage in the sacroiliac joint motion to control the excessive counter nutation will be the posterior sacroiliac ligament, right? So we mentioned that earlier. So posterior sacroiliac ligament will check counter nutation of the sacrum, okay? So will be active during the lumbopelvic flexion. Next, lumbopelvic extension. So coming up from the lumbar spine, we mentioned that the innominates move posterior, and at the end, the lumbar spine starts going into extension. But we didn't mention the sacroiliac joint. So what happens? If we're thinking about the innominate moving posteriorly, we know that the sacrum will go in the opposite direction. So the sacrum will actually nutate. So if the innominates are going in that direction, the sacrum, indicated by the red arrows right here, will be going into nutation motion, meaning that the base of the sacrum will be moving anteriorly and the apex of the sacrum will be moving posteriorly. The two ligaments that I mentioned earlier to stabilize the sacrum from excessive nutation will be the sacrospinous ligament, and we remember it attaches from the sacrum to the spine of the ischial spine of the pelvis, and the sacrotuberous ligament starting from the sacrum inserting into the ischial tuberosity. So these are the ligaments that will be checking nutation of the sacrum. So stability of the sacroiliac joint. So we have stability of the sacroiliac joint can be made from two different concepts, right? So there is a form closure concept and there is a force closure concept. You will dive into it a little bit more with other classes, but this is just an introductory slide for you. So as you can see, the shape of the sacroiliac joint was interlocking irregular surface of the ilium and the sacrum, and the type of the joint, the SIJ joint, is allowed the stability to form. So the shape of the sacroiliac joint articulating, the sacrum articulating with the ilium right here will create form closure, meaning the bones are have a corresponding shape to one another, and the stability will allow to be formed. So, but a second type of stability that we have is the forces coming up from the ground being generated by the muscles of the lower extremities and the trunk, and ligamentous tension force the joint into being stable. So all the muscles, all the ligaments that run from the ilium to the sacrum or from the sacrum to the ilium will create force closure. So force as of the muscle and the ligaments are creating the forceful closure of the joint will provide extensive ligamentous support to the sacroiliac joint. So we have typically the three stabilizing forces at the sacroiliac joint. We have the gravity creating the stability force, we have the stretched ligaments creating the stability force, and the active muscle control creating the stability force. So what is stabilizing force in the sacroiliac joint? So typically the most stable position of the sacroiliac joint will be nutation, right? So we remember the nutation of the sacral base going anterior and the apex is going posterior. So typically it will be referred to as a closed pack position of the sacroiliac joint. So how do we obtain nutation? So in any type of closure, right, in any type of form closure, force closure, we want to create nutation of the sacrum on the ilium. Okay. So that's going to be the most stable position of the sacroiliac joint. So how is that created? So first it's created by the gravity. Because the gravitational line runs anterior to the sacrum, it will create this flexion kind of force, right? The nutation force of the sacral base on the on L5 and as well as the ilium as well. Okay, so gravity once again runs anterior to the sacral base and will create flexion forces or nutation forces on the sacrum. Number two, the stretched ligaments, the stretched sacrotuberous ligament and sacrospinous ligament that runs from here to here, will both create stability in the sacroiliac joint if the sacrum is going into nutation motion. So these two ligaments are responsible for stability of the sacroiliac joint. And finally, we have the muscular reinforcement of the sacroiliac joint. We have the direct attachment of the rectus spinae and multiferi from the sacrum to the vertebrae, which will create the nutation force, as you can tell, to the sacrum. Then we have rectus abdominis, which attaches, of course, to the pubic symphysis right here anteriorly of the pubis, and that will create a posterior tilt of the pelvis of the ilium on the sacrum, and thus creating the nutation of the sacrum. So once again, the posterior rotation of the ilium is associated with the nutation of the sacrum, so that's why the pull of the rectus abdominis will provide stability around the sacroiliac joint. And then finally, we have bicep femoris and glute together, working actually together with gluteus maximus. Once again, producing this force coupled with rectus abdominis by pulling on the ischial tuberosity, producing a posterior pelvic rotation, which will essentially create a nutation of the sacrum and create a stable environment for the sacrum to live in. Okay, and these are the references, and that's it for the sacroiliac joint kinesiology.